You're listening to the Bridge podcast, brought to you by Bridge, New Frontiers in Type 1 Diabetes.
Hello all, and welcome again to this is the fourth in the series of exciting new podcasts. We have got a fabulous group of experts in type 1 diabetes, and no better than our host, or the guest today, so to speak, is Alice Cheng, or Professor Alice Cheng. Alice, I'm not going to spend time talking about you, but I'd rather you did it, because otherwise we'll probably spend the whole podcast talking about what you've actually done. So over to you.
Well, thank you very much, Partha. So first of all, it's an honor for me to be on this podcast with you, someone who's had a tremendous impact on the lives of people living with T1D, particularly in the United Kingdom. So congratulations on everything that you've accomplished. But to introduce myself, so I'm Alice Cheng. I'm an endocrinologist from the University of Toronto in Canada. And just to give a little bit of background for myself, I've been an endocrinologist now for over 20 years, working in a couple of places. So a community-based practice serving a pretty diverse suburban community, as well as an academic hospital-based clinic serving a more inner-city population. And I'd say that the vast majority of the people I see live with diabetes, with about half of them living with type 1 diabetes. And I've had the privilege of learning from and with the T1D community for all of those years.
What brought you interest in the type 1, Alice? I mean, why type 1? You could have, you've obviously had an absolute sparkling career in the type 1. What drew you towards that about as far as you and your career goes?
Well, I'd have to say one of the things that drew me into endocrinology in the first place was the fact that we get to see people. I mean, I'm an adult endocrinologist, so literally from age 18 until could be age 100 or plus. And being able to be involved in someone's life for a long time, and being able to help with a chronic disease, and being able to be a part of their existence, and hoping to guide them in as best as I can is really quite a privilege. And T1D very much lends to that, because we would literally be meeting someone potentially at age 18 and then following them for decades forwards throughout their different phases of life. So that has a big one. That and the fact that it's an exciting field, right? There are a lot of constant changes, whether it be the technology, whether it be the treatments, and as we'll talk about maybe in the future, other things that we can offer. So I think those are the big things.
So it brings me nicely onto a sort of pet topic of mine, because, type 1 diabetes over the years has all been associated with, it's just in children and nothing to worry about. And the UK data certainly shows that a huge number of diagnoses happens in adults, which, apart from the misdiagnosis side of things, is just about awareness. Well, what's your view about the overview? What are the challenges you see with the adult onset type 1 diabetes?
I think the biggest challenge is the fact that everyone assumes everyone has type 2 diabetes when diabetes shows up in the adults. I mean, as you alluded to, more than 50% of new diagnoses of stage 3 T1D or clinical type 1 diabetes actually occurs 18 years of age or older, which therefore means a lot of people with adult onset type 1 diabetes are misdiagnosed as living with type 2 diabetes, and then it's a while later that it actually gets picked up. And then that, of course, leads to inappropriate treatments and delayed insulin starts, which could then increase the risk, of course, of DKA. And not surprisingly, the older the age at diagnosis, the more likely they're going to be misdiagnosed because of that misperception. But in all fairness, though, because I'm sure I've done it myself, right? We probably all have misdiagnosed someone. I think in all fairness, there's understandable reasons why the misdiagnosis occurs, right? I mean, type 2 diabetes is more common than type 1 diabetes. So if you had to guess, then, T2D is a reasonable guess. There's a lack of awareness that it can actually occur in adults. And it may not present with the classic picture, right? There's the classic picture we learned in medical school in the textbooks. And some people may not need insulin at the time of diagnosis, and they may not present with DKA. So then there's a lot of overlap with type 2 diabetes, and not everyone knows about tests that may be available to help them distinguish. So I understand why misdiagnoses occur, but I think part of the reason that we're doing this is to start to lessen that.
And as you said, I think one of the things I find very difficult with, and as you said, it's not just simply due to, we're ignoring it. I think the overlap can be so strong, your pictures with the slightly different body habitus, and you're thinking, could it be this, could it be that, where are the C-peptides? And it all gets very murky. But I think for the listeners, one of the things we wanted to leave out was, or leave the message that it can happen in adults, and a huge number of percentage of adults do have type 1 diabetes. Just bear that in mind, and it's not just, and it's fair to say that even the reverse is true. Children now are having type 2 diabetes, so we should be aware of all the spectrum, so to speak. Well, I'm going to ask you in that case, you briefly touched upon it as part of your initial bit. What about the current clinical tools and strategies to distinguish diabetes in daily practice? What would you say, with all the work you've done, you've been absolutely paramount at setting so many guidelines and being in so many committees. Do you feel like there's been a role with tools and strategies? Any view from you on that?
Yes, the answer is yes. And I think even with the tools and strategies, it does require clinical questioning. I don't know if that's the right word. In other words, always having that index of suspicion, I think, is really critical, because I'll discuss some of them, but there's still overlap. So the ADA, the American Diabetes Association Standards of Care, in collaboration with EASD, they talk about the AABBCC approach to help distinguish the types of diabetes. And that's age and autoimmunity, body habitus and background, control, and comorbidities. So if we go into that little more detail, so around the age part, they're saying if under 35 at the time of diagnosis, think of T1D. Again, not absolute. For autoimmunity, it would be a personal or a family history of autoimmune disease. For body habitus, if the BMI is under 25, then again, think T1D, but again, not absolute. For background, if there's a family history of T2D, family history of T1D, then again, you may think about type 1, but again, not absolute, because the majority of diagnoses happen in people without family history. The C was for control, meaning, and that I think is where the clinical acumen comes in. That's somebody where the ability to achieve glycemic goals is maybe challenging with non-insulin therapy. So you've added something else, but yet it's kind of doing nothing. Then that's when you need to think about, are we missing something? And then that final C was comorbidities. So things that would increase the risk of T1D. So if someone was on an immune checkpoint inhibitor, for example, then you'd be thinking about T1D. Now, this approach, I think, provides a framework and a reminder of some of the clinical things to consider. But of course, it's not absolute in any way. And I think that's where other tools can be particularly helpful. It's more, I guess, biochemical tools to help us. So actually ordering blood tests, as well as thinking about the islet autoantibodies. Now, there are 4 islet autoantibodies that are prominent in type 1 diabetes. However, depending on where you work, for example, where I work, the ability for me to get all 4 is simply not there. So really, the one that I can order readily is the anti-GAD antibodies. So if I'm suspicious, then I will order the anti-GAD antibodies because A, I'm able to order it, and B, if there is the presence of the anti-GAD, then that's a very powerful indicator that, in fact, this person may have autoimmune diabetes and specifically type 1 diabetes. But if the anti-GAD is negative, then there is suggestion to order additional autoantibodies if you can get it, like the IA2 autoantibodies and or the zinc T8 or type 8 autoantibodies. So those are options, but again, maybe not available to everyone. Then there's the C-peptide, and the issue with C-peptide, that may be more readily accessible, but it could be of lesser value, but I will still order it, particularly randomly or after someone has eaten, so almost like a stimulated C-peptide, just to kind of see if there is an appropriate rise in their C-peptide. The issue with that, though, is it's useful if it's very low, it's useful if it's very high, but everything in between can still be challenging.
I think you've probably crystallized not only some of the challenges in this area, what tools we have in our hand, but I think the basic message being that there are things out there to help guide you. Nothing's absolute, but you can definitely be guided, and you have the tips and hints as to which way this may sort of fall. What about, do you feel like, these tools have helped you in your personal space, apart from, do you feel like it's helped? I mean, for me, I found the AABBCC methodology quite useful, to be honest, when I'm doing teaching or for my own purpose. Have you sort of gone through that yourself, or have you got some special nuances or tips you can share from your own clinical practice?
I have used that, and now in that framework, since it was published in that way, but then I think I realized I was sort of doing that, but in a non-structured way. So it was really nice to actually have a framework to think about, and it's easy to remember given it's the alphabet. So that particular AABBCC has been helpful, and I can think of a few cases where diagnoses have changed, right? Where these are often individuals who referred to me for type 2 diabetes. I took it on face value that they had type 2 diabetes, and they were on basal bolus insulin regimens, and you just carried on. And then at one point I kind of thought to myself, okay, hang on, like, is this diagnosis in fact correct? And for a lot of those individuals, it was the C part that triggered me. It was the control, the fact that it was so challenging to try to achieve control, particularly postprandially with their basal bolus, and then having more hypoglycemia. And then I kind of thought, okay, hang on. Then you take a step back and look at them. And then the age sometimes fit, sometimes didn't, but the diagnosis didn't necessarily happen with me. They happened with someone else. And it would be maybe sort of late 20s, early 30s, mid 30s. And then from a BMI perspective, that often did not help because, I mean, people living with T1D can also live with overweight or obesity. So I didn't find that helpful. It was often the C that would trigger me and kind of go, okay, hang on, let me check. And then that's when ordering the anti-GAD has been a surprise, and therefore a learning for myself and also for the individual. And the response has been interesting in that the people have appreciated the change in the label. Partly it required explanation, of course, of what that meant, but it almost became okay, now I understand my journey thus far. I understand why I ended up on insulin so quickly. I understand where these struggles are coming from. And then also, at least where I work, it then opened up avenues for therapy that would not have been available to them had the diagnosis not changed. And then, of course, the safety if they should end up in hospital and not stopping their insulin. So it actually has been very important to figure that out because it changed what we did.
I mean, we've talked about so far as to what's there, what we're going to do, but we are also in exciting times. I mean, I think, everybody's talking about AI, they're talking about, precision medicines around the corner. Everybody seems to be talking about it. Do you see a future whereby all of this gets incorporated to help our diagnosis make it better, or use some tools or apps and stuff? Or where do you see all this heading in the end?
I certainly hope so. And I think that it would make the lives of people living with diabetes, but also I think as clinicians, better in that we would be able to more accurately tell individuals what they actually have, determine what they actually have, and then initiate appropriate treatment. And I actually want to bring up another population, which is the pre-diabetes population, right? Because again, classically, we've always thought about, well, T1D presents in a very dramatic way with DKA presenting to hospital. And yes, that does happen. But then there's also people that just get picked up with some slightly elevated glucose, and everybody assumes that it's type 2 diabetes. And then they get counseled accordingly. But I think particularly with our current tools, but also with the future tools, maybe we can actually differentiate in the pre-diabetes stage, whether someone is going to develop type 2 diabetes or actually it's progressing type 1 diabetes, and then there may be treatments to offer. But the key is that we can then better figure out what someone has. So I think AI is going to be a powerful tool. I think genetic markers and more readily accessible genetic markers and genetic risk scores are also going to be very important. And I think it's going to be, a combination of clinical parameters and genetics to sort out what someone have. And then it'd be great. I could pull up my phone or just on my computer and be able to generate a percentage risk. And then that could then help guide monitoring and guide treatments. And I think that's something to look forward to.
Thank you, Alice. Time flies. But for those of you not aware, if you've heard so far, you will know very well and understand why Alice is the recipient of the 2025 Outstanding Physician Clinician in diabetes, awarded by the American Diabetes Association. So we must take a moment to congratulate you on this well-deserved honor as well, Alice. That's fabulous. And I think our listeners will know exactly why. Well, we come to the end of this podcast, but what I'd like you to do, if you may, or if you can, is some basic bullet points or HCPs to take away from your point of view. Some areas you want to sort of, okay, these are the 3-4 things I'd like you guys to take away. How would you put that in a nutshell, Alice?
Type 1 diabetes can present as adults, and more than 50% in fact does. So have a high index of suspicion. AABBCC as a very useful framework to trigger your wondering and use the tools that we in fact have. So the anti-GAD antibodies, the other islet autoantibodies, the C-peptide in some cases. And even if you've been seeing someone for a long time, take a step back and think about, hang on, could there be a change?
Fabulous. So thank you, Alice. I'm going to we could go on forever talking about this as ever, but I would encourage the listeners to visit this platform, the Bridge platform, engage with all the other people, including Alice, who are trying to do all these educational outputs for the field of type 1 diabetes. And I would also encourage you to come for the next podcast in the series. Before I go on to that, a big thank you to Alice for your time. It was really, really appreciated. On our next podcast, we're going to go to Dr. Mike Natter about the art of communication in type 1 diabetes. But Alice, thank you very much for your time and insight, and hopefully all our listeners will find that to be of benefit. Thank you.
Thank you very much, Partha.
For more Bridge content on type 1 diabetes, including the latest events and initiatives, find us on Spotify, YouTube, and our website.